Dear colleague, today I am presenting the case of a patient who came in at the 22nd week of pregnancy to undergo a second-level ultrasound after the detection of a rounded mass in the fetal abdomen, which appears to be continuous with the umbilical vessels and shows turbulent flow when color Doppler is applied. This is a case of umbilical vein varix, which is a rare anomaly characterized by dilation of the fetal umbilical vein in the intra-abdominal and extrahepatic segment. It has an incidence of 1 in 1,000 live births and accounts for 4% of all umbilical cord anomalies. In fact, the diagnosis is usually made in the second and more often in the third trimester. The average gestational age at diagnosis is within the 28th week. Specifically, the diameter of the dilation can increase by 1 to 2 millimeters, in parallel with the increase in the diameter of the umbilical vein during pregnancy. Therefore, in 60% of cases, there is no worsening of the dilation, which remains essentially stable until term. There are criteria for defining an umbilical vein ectasia, that is, a dilation of the umbilical vein above 9 millimeters, or greater than 2 standard deviations above the mean for gestational age, or a dilation diameter greater than 50% compared to the diameter of the non-dilated intrahepatic segment of the umbilical vein. In the prenatal period, the anomaly appears as an oval or round-shaped anechoic or cyst-like formation, in continuity with the vascular axis of the umbilical cord located in the intra-abdominal segment between the abdominal wall and the liver, and therefore extrahepatic but communicating with the portal system. When color Doppler is applied, a turbulent bidirectional venous-type flow is very often observed. When sampled with pulsed Doppler, in fact, the application of color Doppler is essential to confirm the vascular nature of the lesion, and then to allow for differential diagnosis with other intra-abdominal cyst-like formations. The development of turbulence is often also related to the size of the ectasia. In fact, the larger the adhesion diameter of the umbilical vein, the greater the risk of developing turbulence and the higher the risk of thrombotic events. Umbilical vein ectasia is usually isolated and rarely linked to aneuploidies, in only 2% of cases. When not isolated, it associates 30% of the time with structural anomalies like cardiovascular and urogenital issues, diaphragmatic hernia, ventriculomegaly, agenesis of the corpus callosum, or increased intestinal echogenicity, and in 95% with genetic chromosomal anomalies, notably trisomies 21, 18, and triploidy. The anomaly can result in complications such as thrombosis, fetal growth restriction, fetal hydrops, and fetal demise, which appears to be due to thrombi forming in the dilated segment, leading to obstruction and venous return, or more often at the time of cardiac preload, resulting in cases of fetal heart failure. It is important to note there is a range of differential diagnoses, including other cystic and intra-abdominal formations, which are listed here. This includes a gallbladder dilation, along with mesenteric, hepatic, and choledochal cysts. Cases of enteric duplication cysts are all formations that can be easily differentiated initially by using color Doppler. In fact, they are all cystic intra-abdominal formations, but they lack vascularization, unlike stasis of the umbilical vein. The cord cyst is usually found in the extra-abdominal tract or along the course of the umbilical cord, and as such is negative on color Doppler. An aneurysm of the umbilical artery is differentiated primarily by its location, as it is found at the site of the placental insertion of the cord. And it shows a turbulent flow, but both the pulsed Doppler waveform and the flow are arterial in type, not venous. In the case of an examination focused on the cephalic end, a borderline ventriculomegaly was observed in the lateral ventricle on the probe side, which is the left ventricle. The lateral ventricle appears regular within the choroid plexus, as do the cavum septipellucidae and the insula. The measurement is about 11 millimeters. Observing along the midline the fissures for the vital lobes, we see a regular normal fissure visible within the right tract, that is, the tract closest to the probe, while the fissure for the left vital lobes is not easily visualized. The rest of the anatomy appears regular. We see a small choroid plexus cyst, which is not clinically significant in itself, a contralateral ventricle near the probe, which is normal at 8 millimeters, and a normal posterior cranial fossa. The cranial biometry is also normal and corresponds to the gestational age. Similarly, in the sagittal view, we see a normal corpus callosum. The fetal profile is also normal. Moving on to the scan of the abdominal area, we see the bladder on a higher abdominal plane. We see this roundish anechoic formation that does not communicate either with the underlying bladder or further to the left with the stomach. In fact, these structures are clearly distinct from the formation, which is located to the left of what is the gallbladder on the right and is surrounded by the bundle of intestinal loops. Then, completing the biometry, we acquire the abdominal circumference and we can see the stomach. And next we measure the femur. Both measurements correspond to the gestational age and therefore confirm the absence of any fetal growth abnormality. We then continue to observe what appears to be a cyst-like formation, which, as we can see, is continuous with the vascular axis or with the cord structure. The cord insertion is normal, and we can actually see a regular, normal intestinal mass. The gallbladder is on the right. The formation is located at the intra-abdominal elbow and measures approximately 17 by 16 millimeters, it can be distinguished from hepatic cysts, as it is not actually located within the hepatic parenchyma. First of all, we can see that with color Doppler it is vascularized, and this allows us to completely differentiate it from all other cyst-like formations. Abdominal, such as mesenteric, hepatic, or choledochal cysts, which would not show positive vascularization on color Doppler. Its intra-abdominal location also allows us, as we mentioned, to rule out cord cysts, which are usually found at the extra-abdominal level along the course of the umbilical cord. Even in grayscale, it is already possible to observe a certain continuity with the portal circulation, which we will confirm again by applying color Doppler. In fact, we can see this turbulent flow with a bidirectional appearance, both red and blue are visible, as well as the continuity with the portal sinus and the vessels, specifically the suprahepatic veins and hepatic vessels, in addition to the umbilical cord, and the anterior region of the abdomen. We still observe the continuity with the portal vessels. We switch to the ductus venosus, which becomes regular with the present wave. Once again, we see the continuity with the cord vessels that surround the bladder, more inferiorly compared to the formation. We change the wave to pulsed mode. We observe a typical venous flow, a regular umbilical artery, and a velamentous cord insertion, conditions that could represent an additional risk factor besides the umbilical vein varix for growth restriction during pregnancy. In cases of umbilical vein ectasia, a cardiographic study is essential, considering the complications and cardiovascular anomalies that may be associated. In the four-chamber view, we observe a slight predominance of the right-sided chambers, which we will also see in the three-vessel view, a predominance of the right-sided chambers compared to the aorta, and a slight post-valvular ectasia of the main pulmonary trunk with a normal bifurcation into two pulmonary vessels, right and left, as we will see. Next, the left section of the aorta appears normal and regular. Then in the three-vessel trachea view, the vessels are seen to the left side of the trachea. This condition could be associated with an initial phase of cardiac overload, but there is no evidence of present heart failure, as there is no hydrops fetalis and no pericardial effusion. And we proceeded to sample. The mitral and aortic valves are both currently competent. For findings involving the umbilical vein, perform a second-level ultrasound, specifically fetal echocardiography, to study the heart and fetal anatomy to rule out associated anomalies. Genetic testing, including karyotype analysis and TGH in non-isolated cases, and pediatric cardiology evaluation are recommended. In any case, serial ultrasound follow-up is essential to be performed every 2 weeks to monitor the size of the varix, the appearance of turbulence, thrombi, and fetal biometry. Despite ultrasound follow-up, the onset of thrombosis can be unpredictable. And when this takes place in the venous varix, in most cases, it inevitably results in intrauterine death, with the triggering cause, namely the thrombosis, being discovered and confirmed only post-mortem. In this case, due to the association with ventriculomegaly, a fetal brain MRI and infectious disease markers were also requested. Delivery is generally performed by induction at 38 weeks in the absence of complications. When complications arise, such as turbulence, thrombosis, or cases of heart failure, the approach can be personalized. The timing of delivery, with a shift towards caesarean section, is very often around the 35th week.